Hello, everyone, and thank you for attending today's webinar, Virtual Specialty, Healthcare's Next Frontier, presented by Solera Health. I'm Rebecca Kushmiter, and I'll be hosting this webinar. Just a few notes before we begin. You can read full speaker bios on the left side of your window by selecting the Speakers tab. You can access closed captions from the bottom right corner of your video player. The webinar is being recorded. It will be available for you to watch on demand within 24 hours. We'd love to hear from you. During the presentation, please submit any questions you have using the Questions and Answers tab on the left side of your screen. Time permitting, we will conclude with a Q&A session. All right, now I'd like to introduce Dr. Byron Crow, Chief Medical Officer at Solera Health, will be moderating the webinar. Dr. Crow, please go ahead.
Well, thank you, Rebecca. It really is my pleasure to get to join with some amazing peers in their organizations today and talking about an exciting topic of virtual specialty, what these new care models look like, how they're making an impact in healthcare more broadly, and getting the chance to engage with a really great community here who's interested in how these care models can make an impact in their organizations. By way of background, I'm a practicing internist and, as Rebecca said, Chief Medical Officer here at Solera Health. We are a digital platform company working with each of our panelists today and their organizations, 9am Health, Oshi Health, and Vori Health, all virtual specialists delivering some really exciting innovations in this space, and we'll get to that in just a second. Thinking about our agenda today, we're going to touch on a few key topics. The first, defining virtual specialty. What is virtual specialty? How is it different than not just obviously brick and mortar medicine, but telemedicine and other non-in-person modalities that we all have experienced before. We'll walk through case studies from each of our partner organizations, hear about how they deliver distinct care models within virtual specialty and the outcomes they're seeing from those care models. And then what does the future look like as virtual specialty becomes a much more widely utilized modality of care? How do we see this growing and expanding within our healthcare ecosystem? In particular, we'll touch on how these tech-enabled care models actually create not just ways to access really talented specialists, but have distinct advantages in being able to leverage technology for the future. And then we'll open it up to a Q&A. We'll take your questions, answer them as best as we can, and we can wrap up right around 1 o'clock. I'd love to introduce the rest of the panelists today. I'm joined by three amazing physician peers. I'll let them introduce themselves, but we'll go Dr. Waring, Dr. Berry, and then Dr. O'Connor in order.
Hi, everyone. Nice to meet you. My name is Avantika Waring. I'm an endocrinologist by training, and I'm the Chief Medical Officer at 9am Health, where we provide virtual cardiometabolic care. Just really happy to be joined by these amazing physicians and share what we're doing with all of you. By way of background, I am based in Seattle. Our company is located in Encinitas, California. I have kind of been back and forth across the coast, originally from the East Coast, but have sort of done my training and most of my practice on the West Coast. And more recently was the medical director for the diabetes program at Kaiser Permanente in Washington State. So happy to be here today.
Great. Thanks, Byron, and to the Fierce team for setting this up. My name is Samir. I'm a gastroenterologist by training on faculty at NYU and also the co-founder and chief medical officer at Oshi Health, which is a virtual accountable care practice focusing on conditions affecting the digestive system. Really excited today to talk about, GI specialty care. GI is a condition area where traditionally people don't think of telehealth as a adequate modality, but we've learned over time, especially with the pandemic, the right way for these new specialty models of care to interact with the brick and mortar system. And so, very excited to have this discussion with my esteemed colleagues here, and I'll pass it over to Mary Connor.
Thanks, Samir. Mary O'Connor, delighted to be with all of you today. I am co-founder and chief medical officer at Vori Health. I'm an orthopedic surgeon by background, and Vori Health is a virtual nationwide musculoskeletal medical practice. Our focus is getting people better without surgery. So co-founded by two surgeons, kind of an interesting pivot because we recognize there's unfortunately, a lot of inappropriate and unnecessary surgery and advanced imaging. So I'm really looking forward to sharing how we can transform the delivery of care in multiple specialty areas, as you will hear in the virtual setting.
Well, thanks everyone. We're going to have a great discussion. I think it's a really interesting comment, Mary. It might seem counterintuitive for two surgeons to found a company trying to avoid unnecessary surgeries, but who better than the surgeons, the other specialists, at recognizing not only when to do something, but when to do something differently, when to be conservative. And I think that's going to be a really important theme that we see across our talk today. So kicking us off, I'm going to spend a little bit of time talking about this broader worldview of virtual specialty as a new site of care, and then hand it off to the group to talk through the rest of these other areas of focus. But thinking about, taking a step back in thinking about healthcare more generally, we all have an understanding of what a site of care is when we think about the traditional in-person system. We have hospitals, we have clinics, and then more recently we have urgent care, ambulatory surgery centers, these specific focused sites of care that deliver a level of intensity, a level of expertise, a level of capability. We all have a sense for that. In the past, 30 years, there's been an interesting evolution in not only are we taking the brick and mortar system and expanding it, think about, again, rise of urgent cares, ambulatory surgery centers, other retail clinics, right? New ways of delivering in-person care, but also trying to take those in-person interactions and do what we can remotely, right? This is telemedicine, either video chat, phone call based. So how is virtual specialty different as a new site of care? What does it actually mean to say it's a new site of care within the ecosystem? And we think about that a few ways. One is it's a distinct care model where you're bringing a distinct set of experts, both physicians and advanced practice providers, other non-physician members of the workforce, all together in a shared space, in this case, a virtual clinic on a virtual platform, and with a distinct billing model, in many cases, really innovative value-based payments. And we think about this as representing something that really is different. I mean, it's obviously not brick and mortar traditional care. It's also a leap beyond telemedicine. And so I'll kick it over to Avantika for our second bullet, differentiating virtual specialty from telemedicine. Can you, thinking about how this is moving beyond what we would otherwise think of as telehealth approaches, how do you see virtual specialty being really distinct in this space?
Yeah, I think we're all sort of still learning how to define these terms. They are relatively new, but I really like to focus on the fact that virtual specialty, we're not just digitizing sort of the brick and mortar model. So a traditional, or, I guess to call telehealth traditional is sort of a funny thing, but in a traditional telehealth encounter, we're really sort of translating what would happen in a clinical office that's generally a fee-for-service model. So you'll have, an acute or episodic visit, which often will generate referrals to other services or specialties to other types of clinicians. And, you're not really overcoming a lot of the barriers that people have traditionally had to accessing care. You still have wait times. You have to wait for that individual clinician to be available. You have to schedule the appointment. You have to do it in a certain way. With virtual specialty, we're really thinking about being maximally flexible in a way that we can provide sort of the highest quality of comprehensive care to folks anywhere and anytime. And that means that we'll maybe start with a digital pre-visit so we can gather all that information and the care journey would actually start immediately. So wait times are essentially eliminated. And then moving to just this multidisciplinary model, this is something that's very hard to sort of create in a traditional telehealth model. But in our virtual specialty models, as you'll hear, we're able to leverage a variety of different clinicians and allied health professionals into one integrated platform so that people get like truly the highest level of comprehensive care that they need. I think, yeah, Samir and Mary probably have other thoughts about this as well. So.
So I'll go and comment on the next bullet point about really exploring the role of virtual specialty in the healthcare ecosystem. And I think the important point here is that virtual specialty care can intersect with the entire ecosystem, because it's not just a bridge from primary care to in-person specialty care, but it can be from the emergency department, urgent care, and hospital. And this bridging can be bidirectional. So that means that the virtual specialty clinician, could be referring patients for in-person care, if that's the appropriate clinical setting, and the in-person clinician could be referring the patient for virtual specialty care if that's appropriate and reasonable. So I think it creates a very exciting future ecosystem for us.
Well, Mary, can I get your comment on this this concept of a bridging clinic, and thinking about how a virtual specialty clinic can interact with all the different parts of the healthcare system that we all are very familiar with, and how that can compare or contrast with how a traditional specialty center might interact with those different parts of the healthcare ecosystem?
Well, I think along the line of Avantika's comment, virtual care can be much more convenient and quicker and easier for a patient to access. And that is a really important point. So I think that simply providing that level of access now at the specialty level is going to help patients get care sooner. And typically, care that is delivered in a more timely manner is going to be more effective. So there's just, we have to stop. I suggest that we stop thinking of the healthcare ecosystem as just only in person or only virtual, and start thinking of it as a blended hybrid model. That is really what we need to achieve, where patients can flow seamlessly from virtual to in-person and back again.
Well, I think this gets into a really important concept around enabling these models, which is billing and the financial model. And I know Samir has many opinions on how this can be done well and even better. So Samir, take it away.
Yeah, I mean, I think a lot of the things that Avantika and Mary mentioned around, access, novel care models that haven't existed before in specialty care, the topics Mary brought up on hybrid care and appropriate site of service, doing these things well requires an internal reallocation of resources from the practices side to non-billable services, right? So if you start to think about historically, why haven't these models been as ubiquitous as they are today? It's not that, Avantika and myself and Mary don't know what patients need. The challenge really has been, is it requires you to perform more non-billable services. And that's really hard to do. And so part of the unlock that's really allowed some of these companies to offer patients things like rapid access, a focus on lifestyle, a focus on being able to treat commonly overlapping conditions, has started with going to purchasers and saying, we need to redesign our billing architecture to enable these virtual subspecialty models to do what they need to do in a different way. And so, hopefully there'll be some questions later on the panel on how each of us are approaching billing and working with purchasers, whether they be health plans or employers.
Well, there actually is already a question. We're going to save it to the end, but it's already on folks' minds. And I think your point about, hey, in the traditional world, there are a lot of services that aren't reimbursed, but are really necessary to get the most value out of these kinds of models. And this model unlocks a lot of that flexibility. I think it's a great segue into, Samir, your section. We're going to talk about the case studies, and we're going to start with Oshi. So we'll learn about for each of your organizations, we'll talk through the care model, and then walk through key outcomes for each in about 5 to 7 minutes per organization. So Samir, we'll kick it over to you to tell us about Oshi.
Great. Yeah. And so I think I want to start off by telling people why digestive disorders is a condition area that we should be focused on. Traditionally, CMS, CMMI have really focused on things like MSK, kidney disease. All of us understand the impact of diabetes, but I frequently get questions of, where are the gaps in care for GI? Why is GI a specialty area that needs any sort of innovation? And so I do find it surprising that sometimes people actually do underestimate the impact of digestive disorders, right? We spend more on this condition area in the United States than we do on heart disease, mental health, or trauma. That's a statistic from the NIH. Twice as many patients are impacted by GI symptoms or disorders than patients with diabetes, about 1 in 4 Americans. It's the number one reason that people visit the emergency room, but then are not admitted to the hospital. So again, a surrogate marker for an avoidable ER visit, number one reason is GI conditions. When you start to think about the impact on patients' lives, these are conditions that usually are impacting patients fairly young. And so patients with IBS, a condition area that is frequently associated with low morbidity and mortality, these patients actually report worse quality of life scores than patients on dialysis. Patients with inflammatory bowel disease, that's Crohn's and ulcerative colitis, willing to give up 15 years of life expectancy in exchange for an immediate cure. So the impact of these conditions is really much greater than people think. So what solves these problems, right? We actually have known for a decade that multidisciplinary care, addressing the overlapping behavioral health disorders that can really make these symptoms a lot worse, identifying dietary triggers, giving patients access to a health coach to help with adherence. These are the care models that are used at academic tertiary centers of excellence. So that's the care model we know works. The challenge is we haven't been able to bill for it. And so to touch on what I was talking about earlier, it's not a paucity of clinical evidence that has, confused clinicians. It's really the fact that we haven't been able to bill and scale these services. Now, telehealth works really, really well for things like access to a dietitian, access to a GI psychologist, access to a health coach. And so how can we do what Mary was talking about, where we can marry the best of in-person care and virtual care to provide patients with the clinical model that we know works? And so what we're doing at Oshi Health is really scaling access to this multidisciplinary care. We're working today with national health plans, risk-bearing primary care groups, self-insured employers. We're proud to be partnered with the American College of Gastroenterology and the American Gastrointestinal Association, as well as a lot of large gastroenterology groups to help them provide these services to their patients. And on the next slide, we're also really happy to say every single patient that comes to our practice gets access to the care team you see on this slide, right? And so it's access not only to a medical team, the gastroenterologist and the nurse practitioner, but it's unlimited access to a dietitian, a psychologist, a social worker as well, and a care coordinator. What's important to note on this slide is none of this is being billed through fee-for-service. And so we allow patients to interact with these clinicians in synchronous video visits, asynchronous chat, up until they feel better. That's our goal. We have some patients that have 40 visits in a year with this clinical team. And you can imagine in a fee-for-service model, that would be very, very challenging for a patient to go through that sort of billing architecture. We've studied this model in a clinical trial, and this was a prospective clinical trial where the analysis was done by United and Optum, and we were really proud of the results. Any gastroenterologist on the call probably will not be surprised that if you give these patients access to high-touch care, where they're interacting with a clinical team every 2 weeks, having 45-minute visits on weekends and on evenings, you're going to drive high satisfaction. You're going to drive symptom improvement. You're going to drive improvements in quality of life through improved patient engagement, and then pretty significant and statistically significant cost savings as well. This mirrors what we've actually seen in randomized controlled trials, comparing physician-only care to physician plus multidisciplinary care in these complex GI patients. So again, not surprising results, but very helpful for us to be able to unlock the billing architecture that we were talking about earlier that makes delivering this sort of care possible.
Well, Samir, it's I always love this case study and this trial and the results. And I just wanted to ask one follow-on question because it ties into something we've talked about before. You mentioned some patients in the model who can have upwards of 40 encounters in a year, not to mention ongoing asynchronous communication. And as we think about the distinction between, again, virtual specialty and either brick and mortar or telehealth approaches, I'd love to get your take on, if I was to say, well, what's different between what's happening here and then having telehealth check-ins and sending in-basket messages to a telehealth GI clinic? Like, can you help tease that out a little bit?
Yeah, it's a great question. And I think it touches on what Avantika started the conversation with, that virtual specialty care is not just taking in-person clinical workflows and layering telemedicine on top of them. Most of the clinicians on the call will probably mention they hate their telehealth days if it's intermixed with in-person care. It just doesn't work well. So the other thing I'll mention, Byron, is I don't see it as an either or, right? Virtual and telehealth are just tools. They're not a panacea to solve all the problems in subspecialty complex care. And so the right approach is trying to figure out, when does the patient's problem solvable in a virtual first approach? When does that patient actually need to be seen in person for a physical exam, a cross-sectional imaging study, an infusion of a complex biologic medication, right? So understanding and using technology to tease out when the patient fits into one of those categories is really the right way and responsible for the outcomes that you've seen here. So, we don't see this as virtual or in person. We work very collaboratively with our brick and mortar GI partners to be able to deliver a lot of high touch care. The last thing I'll say to answer your question as to what makes this possible, I'm probably going to go back to this too many times in this webinar. It's the billing architecture that unlocks this ability, because in my brick and mortar practice at NYU, even if I wanted to see a patient every 2 weeks, my practice is just not set up to be able to handle that type of volume. I'm not able to give my patients 45-minute visits with a dietitian and a psychologist. So it's just really around the billing architecture that unlocks the right clinical model.
Well, it's a important point I think you raised too around it's not a standalone offering that lives in isolation. It's in tight collaboration with all these other components of the healthcare system. And Mary, it's a great point to lead into your slides. You touched on this exact point earlier, and I think as we talk about the Vori model, we'll learn even more about how you're thinking about it. So,
okay, great. Okay, so just to introduce us, we are a virtual first nationwide medical practice in MSK. So integrated care teams led by a specialty physician who's a non-surgeon. Why? Because unfortunately we know that most orthopedic and spine neurosurgeons and even a lot of PCPs, unless they've had a sports medicine fellowship, really are not well trained in non-surgical MSK care. We also firmly believe in what we call hybrid care. Not all care can be delivered virtually, but not all care needs to be delivered in person, which is a theme that you've heard everyone say. We focus on personalized care plans and what matters to the patient, not what is the matter with them, which is a subtle, but I have found powerful distinction as we guide patients on, their journey to improve. And of course, some patients still need surgery, but so many fewer, as I'll show you in some of the data. So we use AI to help us drive engagement with our sensorless physical therapy platform. And I have a slide on ROI. So let's go. This is basically the pretty picture that shows on the left-hand side the current system, which and all of us have been patients at some point, remains unfortunately very fragmented. Nobody talks to each other in the traditional system. Maybe if you're lucky, somebody's actually looked at the clinical note from the other clinician. So like the same theme that you've heard, before, we're focusing on an integrated care delivery model with an emphasis on a biopsychosocial approach. So we're also very big on health coaching and behavior change because these are factors that impact patients with MSK conditions significantly. For example, if I just took patients with low back pain and did nothing but focus on improving their sleep, I would improve their back pain. And in the traditional world, nobody has time to even talk to patients about how well they're sleeping or try to give them some helpful tools and coach them to improve better sleep. So we have a care team. Patients get a doc, PT, health coach. We pull in a registered dietitian if more advanced nutritional support is needed. Next slide. So I just sharing some of our outcomes. We had 2 populations of low back pain patients reviewed by the Validation Institute, and this is just some of the results from there. So first of all, 77% of patients improved in their pain. With a more recent cohort looking at Medicare Advantage patients, we had 90% improvement at 2 months. So really, really excited about that. What you'll see in the center there, I'm sorry, Byron, if you go back, is our actual surgical referral rate. So it's just under 3%, and an injection rate of about the same. And if you look at multidisciplinary care, this is what's in the literature for what I would call more high-functioning, in-person, multidisciplinary spine centers. And then on the far right, usual care. So you can see in-person multidisciplinary care dramatically lowered the rate of lumbar spine surgery compared to the one-off usual care. But we've been able to drive that even lower. And I think a lot of that is engagement of patients, getting them doing their exercises, health coaching, and really promoting that non-surgical care first, recognizing that some patients still need surgery. Next slide.
Mary, can I ask one question on this, just to
Absolutely
draw a parallel between what something Samir said and what you're talking about? It's really interesting to me in our conversations and here to think about multidisciplinary care, even when a practice can be very high functioning and bring everyone together in person. We know that's better than usual care. And we're seeing substantial benefit even above and beyond that when that multidisciplinary care team is delivered virtually. And it seems like part of the common thread here is because virtual is so accessible, because you can create the mechanism to really have a lot of touch points with the patient and to have all of the disciplines working together, you can drive toward these better outcomes. And I wanted to get your take on that from a orthopedics perspective.
You know, I just come back to it. The convenience is so important to the patient. I mean, we're so, in the traditional world, we're so doctor surgeon centered. I'm so important. You are going to come to me as the patient. Okay. You're going to meet my schedule, as opposed to recognizing that if we make it more convenient and easier for patients, they will engage more. And, you know, I'll share a story. There was a patient who had knee replacement surgery. Actually, right before I joined Vori, we were piloting telehealth, tele-PT post-op. And we started her on this program. And my initial thought was, oh, she's not going to be interested. She's 85. She's going to be tech adverse. And of course, that was my bias, but she loved it. And I said to her, why do you love it so much? She said, I don't have to get dressed, make sure my house is clean, put the dog in the spare bedroom for the physical therapist to come to my house to do home PT. I don't have to have my daughter take time off from work to drive me to physical therapy. I love my virtual PT. Don't take it away from me. And we see that consistently with the ease of our patients seeing our doctors, seeing our health coaches, asymmetric chat. So it's really like, let's bring care to the patients. That's really what we should be doing.
Well, I love that. And it's a great segue to not only the clinical benefits, but your wrap-up slide here with the improvements in the economics of the care model.
Well, this goes to, you know, all the other points that have been made, because basically redefining the model for virtual MSK care drives substantial savings in healthcare costs. And our approach has been validated in an independent review by Milliman, and we've shown that we can reduce the average spend to treat most common MSK conditions by $2,000 to anywhere $10,000, which could translate to a 4-to-1 ROI for employers and health plans. So they get it. The people who are paying the cost of healthcare understand how much they're spending, and they're really looking for ways that are going to help drive savings while, I believe, still preserving good care for their members. And that's why we're so excited to be doing this.
Well, I really, you made me have a bit of an epiphany moment, right, live on the call, Mary, which is, we talk so much about specialty care is very expensive. It's heavily gated, right? You have to go through your PCP. You can only have so many visits in a given year. It can be in some ways a hot topic around cost control. And yet in these care models, we're seeing that actually being able to deliver more access to a specialist and a care team that can spend that upfront time and attention helping you get to the best place actually leads ultimately to reduction in cost by avoiding these high cost procedures, high cost encounters.
I'm sure every one of us on this webinar, and probably a lot of people on the call today, have been involved in quality work. And almost always, I would say 95% of the time, when you improve quality in healthcare, you lower cost. This is like a no-brainer. We already know this. And that's really what we're trying to do here. Not just improve quality by making it a model that doesn't just focus on, you have knee pain, you have arthritis, I'm going to give you a cortisone shot, and send you to physical therapy. I'm also going to help you with your obesity. Why? Because that creates a pro-inflammatory environment in the body that just puts the patient on this vicious cycle. I'm going to help you with your stress. I'm going to help you with sleep, right? We're going to help you on a journey to improve your MSK condition. And by doing so, because of all these other levers that impact your MSK condition, it's also going to improve your overall health, improve your heart disease, diabetes, depression. I'll go to the central theme. It's all about movement, okay? Even for people with GI conditions, physical activity is important. For people with heart disease, hypertension. So if you have joint pain and you can't move, all of these other conditions are going to be worse.
Well, the intersection of MSK and cardiometabolic health couldn't be a more important topic as we, Avantika, get to your section.
Perfect timing, yes, exactly.
I was just trying to tee you up nicely.
I love it. It's great.
Avantika, the floor is yours to tell us more about 9 a.m. Health.
Thank you. So at 9 a.m. Health, we provide cardiometabolic care virtually, and it truly is end to end. And I appreciate that, everyone on the call understands that diabetes, obesity, and metabolic health are the most important and essential condition to talk about. I'm teasing, but it is actually really awesome to hear that we're focusing on this from many different angles, and that there's a great awareness that, metabolic health is important, not just for your blood test results or, for the number on your scale, but really to help you be kind of happy and healthy and move around the world in a way that feels good. And so what we do at 9 a.m. Health is we bring all the components of a metabolic care clinic to the member. So this includes the very, very important lifestyle features. So nutrition and fitness coaching, help with movement, including for those who have mobility issues. Patient monitoring. So, one of the things that we rely on a lot in the brick and mortar environment is people having devices that they use at home, and then they bring the device into the clinic and we hook it up with a cord and we download the data. Well, we've essentially eliminated all of that kind of barrier by being able to integrate cellular connected device data into our system that helps to guide that sort of day-to-day therapy. Behavioral support, so important when people are trying to make true lifestyle changes. We use a variety of methods. We're very focused on not having a one-size-fits-all approach to nutrition because it doesn't work unless it's inclusive. But then once we get beyond sort of the lifestyle components, people do need medications, and medications have a really important role to play. And so allowing that to be integrated into our program as well, with physicians, including specialists who provide both virtual sort of live care, but also a lot of asynchronous care by way of messaging, texting, and sort of team-based coordination with other scope of practice providers like clinical pharmacists, dietitians, and nurses. And finally, the lab testing. I think anyone who's kind of worked in a specialty clinic before, we've had our patients who have waited 3 or 4 months to come see us, and they don't get their labs done beforehand. Maybe not as important for MSK, but if you haven't gotten your labs done, gosh, your endocrine visit is going to be very, very challenging for us to make it productive. And so we actually bring the labs to the member. So we have a variety of ways for people to get their lab testing done at home. The results come into our system and again are sort of integrated into our algorithms to help guide therapy and treatment. We can go to the next slide. So you might wonder, with all of this sort of robust services and the variety of professionals that we have working with each member, how is this cost efficient? And I think it does come back to kind of what Samir and Mary have already described, that if you unlock that billing model and you allow people to provide non-billable services that we know are super, super effective and highly patient-centered, we do get great outcomes, and great outcomes drive savings. So if you want to think about, we also had an independent analysis done with Melanin of our model, just thinking about the kind of drivers. And I think can you go back real quick? Thanks. Sorry. Some of the drivers of how we drive this ROI include, of course, sort of the obvious ones. So, if you're doing your care virtually, either on a video visit that's included in a bundle payment or async care, you're obviously not paying this fee-for-service rate for those office visits. But I think more importantly, when you make people healthier and you're there for them kind of continuously whenever they want to pick up their phone and text, they're not going to need to run to the emergency department or the urgent care to get a refill or, because their blood sugar is high. And then I think one of the really important things that we do in our work, particularly with our PBM and health plan partners, is look at the way that medications are being prescribed. So we all know that there are a lot of medications out there that are high cost and lower value to the member, or maybe not aligned with the formulary. And so that's one area where our physicians can, in our system, our product can help kind of prescribe in a way that saves everybody money, not just the payer, not just the employer, but also the patient, because the copays are lower and they're more likely to take their medications if they're affordable. And then finally, anyone who has had any kind of interest in cardiometabolic space these days is talking about GLP-1s. So one of the other ways that we can really drive ROI, especially for sort of employers who are looking to offer these medications as one of the tools in a toolkit for weight management, we see that if we can put people through a really comprehensive lifestyle management program and use step therapy, we can make sure that the people who get GLP-1s, these costly medications, are getting them for the right indications and in the right way. We can go to the next slide. Thanks. And this, again, I want to share these outcomes because they're awesome, but also this should be no surprise. There's plenty of data published that shows when you really focus timely, frequent touch points with a multidisciplinary care team for chronic conditions, we do see great results. And so, the drop in A1C of 2 points in our folks with a baseline that was 8 and above, that seems like a big drop compared to a coaching-only program, but anyone who's worked in a clinic where we've had this type of model will know that this is what you should expect, because this really is the type of care that people need to get better. We can go to the next slide because I do want to make sure we have time for questions at the end. Just one other point I just want to really focus on is the health equity piece of this virtual specialty model. I think there are, what we describe as the sort of multidisciplinary, high quality care, it can be found in in-person settings, but that might require having the ability to navigate complex sort of coverage issues, figuring out where you have to travel to get this care, being able to advocate for yourself as a patient to tell, your PCP that I need to go to this place to get care. And that can lead to a lot of health inequities because not everyone who needs this level of care is able to access it. And so I think in addition to just proving that we all have great outcomes, one of the things that is imperative for all of us is to continue to assess whether we're meeting populations equitably. So our patients with different language needs, different backgrounds, racial and ethnic backgrounds, different cultural needs, are they all being met with this virtual specialty solution? Because that is a way that we really can kind of be far and above more successful than the traditional system where we know these gaps are very prominent. We can go to the next slide.
Well, the next slide is future direction.
Perfect.
So a wonderful place where we can talk about a few of the follow-ons to your lovely presentation on 9 a.m. Avantika. So as we think about virtual specialty as this new frontier of care delivery, I just want to touch on a few things that this group has talked about before, but even come through even more loud and clear in our conversation today. The first being the ability of virtual specialty to create a new care model that allows for just simply more access and back and forth between patients and their care team in a way that leads them to make better decisions for themselves. I think, Mary, your comment was so good earlier around we're asking how we can help patients, not just what's wrong with you.
What matters to you?
What matters to you? Thank you for filling out I was grasping for it, but yours is the more elegant version. What matters to you? And when we actually spend the time and learn about what matters to patients, it turns out that a lot of folks are not simply ready to jump into surgery, or don't just want to go straight to the endoscopy suite, or don't just want to get started immediately on a GLP, but actually make a more thoughtful decision and work on other things before they jump to a high-cost procedure or a medicine that they're going to have to take for the rest of their life. I think the other piece.
I'll just add one thought there. We are, as much as we might try to think that we're rational human beings that make decisions based on data, we are emotional human beings. And when we create a care plan for a patient, which starts with what matters to you, right? We're focused on that. For example, right? I want to run a 5K, or I want to go play with my grandchildren. That is what emotionally engages the patient to drive them to do the things that we're asking them to do to improve, because that's what they want to do. They want to run that 5K. They want to play with their grandchildren. It's not just, I want my back pain or knee pain to go away. And so it really creates a more positive environment in terms of here's what we're working towards that we believe helps drive engagement and satisfaction from patients. Thank you.
And to that point that, Mary, medicine is a team sport. It's a team sport for the care teams, and it's a team sport for the healthcare organizations, whether it's a virtual specialty clinic or a major health system or independent private practice. Virtual specialty isn't standing alone as some new frontier that's trying to take over care and do everything and be gone with in-person care. That's not what any of us are saying or thinking, but actually work as a really important place within the existing system to support the activities that we know we all are working toward, but using this different care model to the best of its ability. Avantika, your last slide on health equity and the ways in which virtual specialty can really make an impact in that area was a great way to, I think, lead to our next bullet around overcoming barriers to care. Could you spend some time talking about how you think about virtual specialty as really a way to get around a lot of these barriers to care that occur in other parts of the system?
Yeah, definitely. And I can share with our 9 a.m. health experience. We started initially as a largely direct-to-consumer offering, and we did actually it was really interesting, the learnings we got for the folks that came in. It was people who were uninsured, underinsured, recent immigrants or refugees who really had no way to access or tap into the U.S. healthcare system. And so I think, while we now are serving a lot of commercially insured folks through employers and health plans, the learnings there were so valuable because we really learned how to provide excellent care despite a lot of other adversities, whether it's financial struggles, so really leveraging generic medications and helping people navigate through different government assistance programs and things like that. And then also just cultivating, especially on the lifestyle front, resources that are very inclusive. So not just, for example, the standard recommendations that you would get on a website or through one organization that caters to a specific population because they're located in a certain area. Because we're available in all 50 states, we kind of have to have resources available, whether, you live in the South or you live in the Pacific Northwest or you live in the Southwest, and whatever your access to different foods and weather for exercise. I mean, there's so many things that come up that we don't always think about when we're going into clinic and dealing with our population. So I will say that's something that's very, very important for us, is just continuing to expand upon that. But I think some of the things I mentioned, geography and barriers are huge. And most of us have sort of trained and practiced in these large academic centers where you are so important and everybody wants to come see you, but that sometimes requires driving 4 hours, getting a hotel room or a flight, right, for your specialist visit. And that is just not a reasonable thing for most Americans to be able to do financially, or, when it comes to taking off time work or caring for your family. It's something that a very, very select group are able to navigate. And so I think our mission as virtual specialists is to give everyone that sort of center of excellence experience, no matter where they live, no matter what their, specific kind of financial situation is. That's my goal. I feel really strongly about that because it works and it's affordable and effective. And also patients love it. So patients love being able to text their dietitian, chat with their health coach. Around the holidays, people will say, oh, we have some stressors coming up. Like, can you help us redesign our plans for the next 2 weeks? Even if you have the best physician team in the world, they are not going to have the time. And I can say from experience, we don't have the time to do those minute by minute, helping hands. So I think we have a long way to go, but it is something that we need to stay on top of, is thinking about any additional barriers we see and how we can work to overcome those, because we have the power to do that in this model.
Well, with that in mind, I mean, you raised the point about academic medical centers and centers of excellence, and those are not going away. They're expanding, and they do a ton of amazing work. And I think Mary and then Samira, it'd be great for you to comment, especially thinking about surgery and GI, where you're having to work in partnership closely with surgeons and proceduralists. How you navigate this future of hybrid models and how you see things evolving there.
All right, I'll start, and I'll sound a little pessimistic here at the beginning based on my personal experience with the large traditional academic healthcare system, which is fundamental change in these traditional systems is exceedingly difficult, okay? I mean, I think I have like cranial hypertrophy from beating my head against the wall, right? So and it's very hard. I don't think they're bad people or ill-intentioned people. The problem is the payment model. Every healthcare system in this country's financial margin is generated from surgery, advanced imaging, and procedures. And any model that's introduced that decreases the rate of those procedures, which is what funds everything else, funds pediatrics, it can fund OB for low-income women. I mean, it's what they need to do to financially survive, because the payment system is so messed up. And so it's really, really difficult for those groups to affect change when they are trapped, held captive in this payment model. And that's why we have the opportunity to innovate. And I am completely aligned with Samir's comments that the billing model is what allows us to deliver the multidisciplinary specialty care that we do. So we got to innovate in this space and then basically drive the change, because places where we would look to for kind of traditional leadership in terms of care pathways and acceptable, care models. It's very difficult, which would be academic centers, very difficult for them to change because of the payment structure that we have in this country.
Well, Samir,
Didn't mean to be a downer there, Byron, but that's the reality of where we are.
Well, I appreciate that, and I think I feel uplifted that there is so much energy going toward creating new and better ways. And I think, Samir, could you round us out as we think about emerging trends and innovations in this space? We're touching on the billing model. You're welcome to spend even more time on it here. I know it's so critical to being able to actually create this innovation. How do you see things progressing over the next 3 to 5 years in this space?
I'll try to answer briefly because there's a lot of really interesting questions that I'd love to get to with the rest of the panel. I think it's obvious. I don't want to hit on the buzzwords of predictive analytics and AI. All these technologies are going to impact all players in our industry. So we're going to use more of these technologies and tools to automate back office functions, give clinicians more times with their patients. Where I see the most exciting trends is actually on the health policy side, right? One of the biggest barriers, and Avantika touched on this, is, we've developed these silos in healthcare because healthcare was purpose built to be local, right? You went to your local hospital, you went to your local primary care doctor, which made a lot of sense back in the day because when you were in the hospital, you'd spend a long time there, right? Now we're shifting away from having a system that is centered around the inpatient experience. We'd rather actually send patients to a really, really good hospital that might be a little further away because their length of stay is going to be a lot shorter. But unfortunately, the policy constructs have not evolved, right? And so today, all of us know if you're licensed in New York, I can't deliver care to a patient in New Jersey, right? And so where I see the most exciting innovation and trend is not in the technology. The technology to do what all of us are talking about is really not that sophisticated. It's revolutionary in healthcare, unfortunately, but outside of healthcare, a lot of this technology has existed for a long time. What's going to accelerate the adoption of technology and accelerate the adoption of new technology, especially with the topic we're discussing of virtual specialty care, are going to be things like breaking down, the barriers to deliver care across state lines, allowing mid-level providers, nurse practitioners, and PAs to practice to the top of their license. Those are the types of things that I'm most excited about in terms of emerging trends and innovations, and hopefully we'll be able to get to some of the other things I'm excited about based on the questions.
Well, it's a great point, Samir, around modernizing our policies to reflect a world where we're no longer bound by local care delivery and we can deliver care remotely across hundreds and thousands of miles. And it plays nicely with a great question in the chat from George, talking about the challenges of scale and scaling the model. When you can have smaller teams, they can often be very high performing. But as the teams grow, as the model grows, we need to take a different approach to maintain quality and maintain effectiveness. How do you all think about that in virtual specialty? What are some of the challenges and opportunity areas?
I mean, I can provide some comment on that, just simply because we're always kind of looking and hiring and growing. And, as opposed to when I was managing a local team, it was actually way harder to hire excellent talent because you're kind of limited to one location, right? So now it's like we can cast our net really widely, use different kinds of networks to hire qualified people who live all over the country, to come and work for us. And then it's true that the training component, they're not necessarily in the office, but, we're able to hire people who have a baseline higher level of skill and interest and passion for what we're doing, because it doesn't matter if they live in Tennessee or South Dakota. we can get them in and build up the credentialing and licensure that we need to meet all of our 50 state patients. But I also think that, it's provided a really nice break for the physician and clinician healthcare workforce. Many of us struggled through the pandemic, and there's a lot of folks out there right now who are looking to do more virtual care, and they've gotten really experienced at it throughout the pandemic because they had to do it. So I would say that scaling is always a challenge, but I find it to be less of a challenge here in this virtual specialty space than I did when I was trying to scale a traditional healthcare team. I don't know what others have experienced.
I totally agree with you. I think the supply demand mismatch that exists with accessing subspecialists, telehealth and virtual specialty care is a perfect way to solve that, because you can take clinicians that live in areas where there aren't as many access problems and allow them to deliver care in areas where there are tremendous access challenges.
I'll add that that's been my experience. We really haven't had trouble with recruitment. Clinicians enjoy being able to work from home, enjoy being able to work from anywhere that they want to be in the moment. And our clinicians are licensed across all 50 states in the District of Columbia. So, which speaks to the point that Samir made, that is an expensive investment for us, right? And hopefully, as we grow and we scale, we'll have pods and not everyone will have to be licensed everywhere. But in terms of scaling, when I think of scaling, I don't think of only how I'm going to grow the number of clinicians that we have on the team. I think about the tech-enabled advances and services that are going to allow us to become more efficient, because we don't want to burn out our clinicians. A burnout clinician makes an unhappy patient. Bad outcome, no go, right? So we're looking at incorporating AI-generated transcription to make clinical documentation easier and faster. We're looking at advancing the AI that we have in our sensorless motion track exercises so that it could automatically provide patients with the next phase of their exercise, their home exercise program, if they meet certain parameters, or alert the PT if they're not on track. So, as we think about how we scale, what is exciting in the virtual world is basically having more opportunity to leverage some of these new tech products and advancements that allow us to scale in terms of patient volume without the same ratio necessarily of clinicians.
Mary, it's a great point too, off of something Samir said earlier, that the technology to do this has existed. It's been about applying it to this specific case and layering on a new care model and a new financial model that collectively is what's driving the innovation.
Correct.
Mary, we have one more question directed for you, and then I think we're going to be at the end of our time. And the question was, you'd mentioned improving quality of life and how you measure quality of life. And I think the general question for the group is about leveraging digital tools for measurement-based care. So how do virtual specialty models make it easier to measure the impact of current care, and actually surface that to the care team to use to make decisions against?
Well, I'll be brief. I think it's just very easy for patients to give us feedback, because the touch of the phone, and everybody in the world has a phone. So that's very helpful. We do, to get more specific with the question, we measure, I would call them standard measurement tools like PROMIS 10, PHQ, GAD2, numeric pain rating scale. And we use those to help us understand how the patients are improving, particularly with pain. But what I find actually more important is, are we helping them achieve what matters to them, as I mentioned before? And that to me is probably the most satisfying thing that we do, when we're able to help that patient get to, go play with the grandkids, run the 5K, whatever it is.
Absolutely. Well, as we enter into our home stretch here, I really appreciate everybody on the call today, getting to spend some time together and learn about these wonderful organizations that are building a incredibly unique offering, something that I think we'll be seeing much more of in the years to come as these models expand, and the innovators here are really driving it forward. So, Mary, Samir, Avantika, thank you. It's always my pleasure to get to talk with you.
Thank you.
And over to Rebecca for our closing comments.
All right. Well, thank you all for attending this Fierce Healthcare webinar and submitting so many great questions today. I'd like to thank our speakers for participating and Solera Health for presenting today's webinar. A recorded version of this webinar will be available for you to access within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.